Welcome, everyone, to this issue of the Neurology Journal Video Club. I'm Bruce Hermann. I'm Professor Emeritus in the Department of Neurology at the University of Wisconsin School of Medicine and Public Health. And I'm delighted to be joined by...
Hello, I'm Taylor McMillan, and I'm a pre-doctoral intern in neuropsychology at the University of Florida, Department of Clinical Health and Psychology, and also doctoral candidate at the University of Maine in Orono. And we're so happy to be here.
Yeah, we're happy to be here today and to discuss the study you can see on the screen, Effectiveness of a Self-Management Program to Improve Cognition and Quality of Life in Epilepsy. I'll give a few background comments to give some context to the study, and then Taylor will go over the methods and results, and then we'll conclude with a few discussion points about the outcomes and importance of this particular investigation. So to get going, by way of background, every study has a story, and this investigation certainly has a very important story. It's concerned with cognitive morbidity in epilepsy. It's very prevalent, and it's been demonstrated in population-based and clinical investigations. There are 22 epidemiological investigations of cognition of some sort in adults and children with epilepsy. And every one shows that cognitive difficulties are more common in persons with epilepsy than the general population. And it's also a major concern that's expressed by parents of children with epilepsy, patients themselves. And it's known that these cognitive difficulties, if severe enough, can have adverse effects on academics and youth with epilepsy, impact ultimate functional status, and even impact life course, and certainly to affect quality of life. So as neuropsychologists, we're great at detecting these issues. We can give tests and be very specific about what's working and what's not working and the severity of the problem. But from there on, it becomes very difficult. The best practices for rehabilitation of cognitive problems in epilepsy is very difficult and remains somewhat elusive, which is where this study and the CDC steps in. The CDC has been long been dedicated, among other things, to the public health significance of epilepsy. In the past, they had Living Well with Epilepsy conferences. There were 2 of those. They developed the Managing Epilepsy Well Network, and from that network came Hopscotch. Hopscotch stands for Home-Based Self-Management and Cognitive Training Changes Lives. And the initial Hopscotch clinical trial was published in 2016. This is a follow-up to that investigation. In the 2016 investigation, they did a clinical trial and demonstrated that Hopscotch, compared to a waitlist control group, improved overall quality of life, and in particular decreased seizure worry and improved cognition on a quality of life measure, and actually improved objective test performance on measures of attention and general cognition. So that provides the essential background for this investigation, which is a pragmatic trial, moving it out into the community and other centers with some tweaked aims and goals. And for that detail, I'll turn you over to Taylor.
So we're going to just briefly chat about the important pieces of this paper, and I think going through that, it'll help guide a little bit of our discussion. I know I have some thoughts, and Bruce, I'm sure you do too, about what they found in this study. But the goal of this study in particular, as Bruce highlighted, was to essentially replicate the findings that were done in the original, or that were found in the original validation study, and really determine its feasibility as a virtual intervention. So they made that slight adjustment here, given the findings from the last paper, as it pertains to how do we generalize this and make it more accessible within the community, given its findings. In general, they kept the Hopscotch intervention pretty similar. They were 45, 60-minute sessions delivered over 8 to 12 weeks. The only difference here was that session 1 and the last session were provided in a virtual format through video. And I think it's an important factor here that this was done before the COVID-19 pandemic. There were various inclusion criteria and exclusion criteria. I think instead of going through them individually, I think just highlighting that the inclusion criteria here was a little bit more liberal compared to the original validation study. Here, they really let anyone with subjective cognitive concerns be enrolled in the study, whereas before there was a specific cutoff score on the QALY cognitive subscale. And there were 85 people that completed the study. 108 were originally enrolled, but they had some attrition. So their primary outcomes were quality of life in epilepsy using the QALY. They also were interested in how people with epilepsy utilize healthcare services. And they were also interested in self-reported cognitive concerns, and that was measured by the NeuroQol. And the PHQ-9, which was a measure of depression, the epilepsy self-management scale, targeting as it suggests self-management skills. And they also gained an objective measure of cognition using the brief test of adult cognition by telephone. And this was a change from the previous study, given its virtual format in this current article. And the outcome instruments were administered across time at various assessments, and they importantly did additional follow-up here, including 3, 6, 9, and 12-month follow-up. So overall, the results were quite interesting, in my opinion. So the HIP is essentially the original hopscotch approach, where you had the in-person first and last session, and then the telephone virtual sessions in between. And that was associated with improved self-reported cognition and quality of life. And there was a 12-point treatment effect on overall quality of life, so a substantial increase in quality of life. Subjective cognition also was significant at the 6-month follow-up, but that effect didn't maintain past the 9-month assessment. The virtual group, interestingly enough, did not show significant improvement in quality of life or subjective cognition, and both interventions failed to replicate improvements in objective cognition. But patients who participated in this study overall continued to report high satisfaction. So overall, there's suggestion that there might be some reduced efficacy in this particular sample. They highlighted a number of limitations, including the way objective cognition was assessed. That was through a brief telephone screen, which is quite different from the last validation study in 2016, where they utilized the R bands that included multiple measures of cognition and then a global score. There was a notable attrition rate, and with any sorts of intervention, recruitment is difficult, and so they had limitations such as small sample size. The location where these centers were located were in primarily rural, white, non-Hispanic communities. And there's some limitations as it pertains to characterizing depression and non-pharmacological treatment, as well as how seizure type and seizure variables kind of interact here. And I think that will lead us nicely into the discussion. And before we do that, we have some terminology. I imagine most of the people who are attending this journal club are familiar with the definition of seizure and epilepsy. But here we highlight the difference between hopscotch and managing epilepsy well, which are explained in the article. And as Bruce mentioned, the Managing Epilepsy Well is the CDC-funded research network to provide evidence for self-management strategies to improve quality of life in those with epilepsy. So with that being said, I'll just leave this results slide up here. And maybe, Bruce, we can first kind of chat about some of the limitations, because I think that will kind of tie in nicely to some of our discussion points that we highlighted in our meeting.
Sure. So, the big issue with this is they say it's a pragmatic trial. So they're taking it from the very controlled confines of a clinical trial, as it were. in a university-based setting, and then sort of releasing it out to the community, 4 separate centers and different people involved, different patient groups, trying to make the methods work. And so at some level, it's the same, but a bit of a different animal. And there's all sorts of moving parts. And the one thing that impressed me about this was how attentive they were to the small details of methods and care and fidelity to the hopscotch procedures and stuff. It really was an enormous effort, both in the past and currently in this investigation. But intervention trials are so difficult. You need to give a lot of measures to demonstrate effect, and that at some level is a double-edged sword. It becomes a bit of a burden for patients. The patients have a known difficulty with transportation back and forth, and so they've tried all along the way to do a telephone based intervention to the degree that they can, with limited in-person visits. And, the trouble with cognitive assessment, sometimes that takes a long time. And so they're trying to be as efficient as they can, reduce burden, and that has strengths and limitations. And despite everything they tried to do, they still had some difficulty with retention. 21% they lost, but it was tied to educational level. And I think to some degree, respondent burden. So those are sort of come with the territory. And I hope they proceed on with this.
I agree. I think it would be very interesting to continue with another sample. And I think kind of tying it back to the attrition rate, it is quite interesting that it was tied to education. And looking at their sample, being in the Northeast and primary rural, white, non-Hispanic communities, I think there is some barriers there, particularly with rural communities in terms of access to care, access to clinicians, access to internet, and just that overall education with the medical system. And I think it would be interesting to kind of reevaluate this virtual format in another population, and that maybe and that help identify the particular exceptions that to make depending on the communities that you're looking at.
Right. They tweaked it from the clinical trial to the replication effect here, and I do hope that they keep going on. I mean, this is the most extended effort to development cognitive intervention, and they have so much experience. I hope they can continue to press on. I will say, in terms of memory, I mean, memory means different things to different people. When everybody comes into a neuropsychology clinic predominantly with memory complaints of one sort or another. And if you say, so give me an example of what you're talking about. I mean, for neuropsychologists, we think memory is a problem in episodic memory and retention over time. But patients will say, well, I can't think of people's names. I go into another room, can't remember why I went there. I go to the store and I forget why I went there, those sorts of things. And so there are a variety of symptoms that swirl around this memory concept. And they've done their best. And day-to-day cognition can be affected by the presence of a recent seizure, quality of your sleep, your motivation, your levels of depression, all these things which make it all that much more complex. But they've tried to really hone in on the concept of subjective complaints, attention in particular, and I think that's they're definitely going in the right direction. I hope they keep going on forward.
Yeah, absolutely. Like thinking about memory as what we know about as neuropsychologists, that it's kind of one of those constructs or abilities that can have downstream effects. With impairments of attention, if you have weaknesses and ability to hold things in mind, that can be affecting your ability to remember things in general. So I think attention is important here, and I do appreciate their address, like the fact they addressed memory as it pertains to verbal memory, because when looking at other attempts to use cognitive rehab in epilepsy, there hasn't been any clinical trials or well-validated trials, but there are some reviews that suggest memory is the most concerning and the most evident cognitive impairment that they experience. So I definitely appreciate that they included that. I think, to your point, we can just highlight some other aspects that can affect memory down the road, whether it be external or internal factors.
Yeah, so every epilepsy clinic center in the world deals with this. This is a global problem. And we're all sort of in the same boat. And I think the managing well with epilepsy concept has been well maintained by the CDC, and there are several programs that come out of that. You can check the CDC Epilepsy Branch website for that. You can find more information about hopscotch online. A lot of this is manualized, not speaking for the authors, but I think if a center were interested in this, they could find the materials, a good deal of the materials through the CDC Managing Epilepsy Well or through the investigators themselves. So I'd encourage people to pursue this. Interests at centers vary. Some are more interested in other aspects of epilepsy, but for those that are interested in improving quality of life and cognition, I recommend this to folks highly.
Yeah, and thinking about the different applications with pre-surgical populations. And I know that was something that they looked at in the original study of how many had surgery. So I think this could be helpful regardless of what stage of intervention that a person with epilepsy is in. And well manualized, like you said, and it's based off of some well-validated strategies like the problem-solving therapy and whatnot. So yeah.
So if you haven't read it, take the time and take a good look at it, and congratulations to the authors. And as I said, I hope they continue to press on with this, and it's really a major contribution to the field. Congratulations to them.
Yeah, absolutely. And thank you all for listening in on the American Academy of Neurology Journal Club series. We're so happy to be here and present this research to you.
Thanks, Taylor.
Thanks, Bruce.